This is Lecture 6, Influence of Drugs and Hormones on Brain and Behavior, and it corresponds with Chapter 6 of your textbook. Reminders and announcements, homework 6 and 4 and 6 are due at the usual time this Sunday at 11 p.m. Your recommended reading for this week is an article detailing some of the similarities neurobiologically between drug addiction and romantic love. So in drug addiction, a large amount of research implicates the dopaminergic mesolimbic pathway, specifically or particularly the ventral tegmental area, the VTA, and the nucleus accumbens. And a smaller body of research has also noted that this area is activated, these pathways and these areas of the brain are activated when somebody is in love, especially with a new romantic partner, so kind of like the intense first stages of love, as compared to a friend. Essentially the brain of someone who is intensely in love with another person is somewhat similar to the brain of someone who is literally addicted to drugs. Now, we shouldn't take this too far and say that like love is literally an addiction or that it's the same as drug addiction, but it is noted that a lot of the behaviors associated with new romantic love are kind of common to drug addiction. A lot of times people only want to spend all the time with that person. Breakups can have some similarities to withdrawal, and in fact, a breakup during this intense love phase is associated with it is similar neurobiologically to withdrawal from a drug. So take the research kind of as it is, but it's an interesting comparison.
Okay, so starting with section 1, most of this is going to reflect the book, but there are a couple areas where I deviated because I either don't necessarily agree with how the book frames something or I wanted to give extra information. I tried to make this a bit more information heavy this chapter, as a lot of you had mentioned that you were particularly interested in how drugs affect the brain and also how hormones affect the brain. So to start out, psychopharmacology is the study of how drugs affect the nervous system and behavior. Psychoactive drugs are any substance that alters mood, cognition, or behavior primarily, and this is both like medications for mental illness as well as substances that are taken for recreation. Most drugs do affect multiple neurotransmitter systems and different parts of the nervous system, including different areas of the central nervous system. We'll try to simplify it in this chapter and talk about the main neurotransmitter systems that are targeted by individual drugs. There are individual differences in how drugs affect a person, so obviously someone who has a bigger body mass is less affected by the same amount of a drug as someone who has a smaller body mass. There's some indication that different genders may respond to drugs differently. Genes actually have kind of a bigger effect on how people respond to drugs than one might expect. Age, and then expectation of drug effects. So whether or not you expect to be intoxicated by a drug or the expected effect of the drug can change how the drug affects you. Importantly, there are many psychoactive drugs that we don't understand the mechanisms for. In fact, for most of them, we don't have a thorough understanding of how they work in the brain. A lot of medications, such as antipsychotics for schizophrenia, antidepressants, we have some idea of how they work, but not a detailed understanding. We just know that they do work. So there are several ways that drugs can be administered in the body. Injecting just straight into the bloodstream. This is a very quick way to inject medications or drugs. Lower doses are needed because it's going directly into the bloodstream. People can also consume drugs orally, like through a pill. This is typically the safest and the most convenient. You don't need extra syringes or anything like that, but it still can be very dangerous. People can easily overdose through taking pills. People can inhale drugs, so think like tobacco or cannabis, where it's absorbed through the lining of the respiratory system. and then patches, where drugs are absorbed through the skin, so a nicotine patch is an example of this. The more barriers there are between the route of administration and the brain, the higher the dose is, the dose of the drug is needed. And just a reminder of the blood-brain barrier, which we talked about before. This is a barrier that's created in part by glial cells that prevents toxins in the blood from easily accessing the brain. This is one way of keeping the brain safe from, for example, if you were to eat something, like if you had food poisoning, you wouldn't want those toxins getting into your brain. Instead, you get sick, physically sick, but at least your brain is not affected unless it's a very serious toxin. But it can also, the flip side of this is that it makes it difficult to administer medications in the brain. Okay, so just a reminder of what agonist and antagonist is, and here's a little picture. So in terms of acetylcholine, an agonist of acetylcholine is black widow spider venom, so that promotes the release. It increases the transmission of acetylcholine. Botulin, which is the toxin from botulism, is an antagonist of acetylcholine, so that prevents or decreases acetylcholine release. Nicotine, as we talked before, is an agonist of acetylcholine, and so on. Their postsynaptic receptors are typically designed for certain endogenous neurotransmitters. So, for example, there are acetylcholine receptors, but these can be activated by other substances that have similar chemical structures. So some acetylcholine receptors, specifically nicotinic acetylcholine receptors, can be activated by other substances that come from outside the body, such as nicotine. Tolerance is a decreased response to repeated exposure of a drug. You're probably familiar with this idea that the more alcohol you drink, if you're a chronic drinker, you need more alcohol to achieve the same level of drunkenness over time. There are three main types of tolerance. There's metabolic tolerance, where enzymes in the liver, blood, and brain that are tasked to break down alcohol, these actually increase with chronic use, and as a result, the users, if someone is chronically using alcohol, they metabolize it more quickly, and this reduces the effect of alcohol, so they have to drink more to get the same effect. There's cellular tolerance, where brain cell activities just adjust to higher levels of alcohol in the blood. And then there's the more psychological, learned, or functional tolerance, where a chronic alcohol user gets accustomed to the feeling of intoxication, and so they don't show as many of the outward signs of intoxication, so they might not slur their words as much, might appear normal. You might have heard the term like a functional alcoholic. A lot of times a chronic user will not notice the effects of alcohol as much as well. And you might note that tolerance resembles habituation. So the flip side is sensitization, which is an increased responsiveness to the same dose of substances over time. So where tolerance is more likely to happen when somebody is chronically using, like using every day, sensitization is more likely to happen when use is intermittent, so there's more time between uses. The book outlines a study in which rats were injected with amphetamines and showed increased behavioral symptoms of amphetamine, so increased motor activity, for example, each time they were injected with these intermittent doses. And what's happening at the cell is that more dopamine is being released into the synapse as the rats are becoming sensitized to amphetamine. Other things that are happening in the cell is that there are more dopamine receptors, so more opportunity for dopamine to have an effect on the postsynaptic cell, and there's blocked reuptake of dopamine, which means it stays in the synaptic cleft longer and has more opportunity to bind to receptors and have an effect on the postsynaptic cell. Drugs with similar chemical structures can actually have very different effects, and drugs with different chemical structures can have similar effects, which makes it very complicated to categorize drugs. Any one drug can affect multiple systems. although, as I mentioned before, we're going to try to make generalizations based on the main behavioral aspects of psychoactive drugs. And notably, drugs can typically have 2 or 3 names, so they can have a chemical name, and then often they'll have a generic name too, and then a brand name, and they can often have several different brand names. For the most part, when I was talking about medications in this next part, I'm using the brand name just because I think it's a little more recognizable to most people. So these are all the groups of psychoactive drugs. Your book used group them by the behavioral characteristics. So there are many different ways to group them, but this is how your book chose to group them, so I'm going to follow that grouping. The first group is anti-anxiety or anxiolytics and sedative hypnotics. In low doses, these anxiolytics reduce anxiety. In medium doses, they're more like they sedate, so people might feel drowsy or tired. In high doses, they can be used as anesthesia or even cause coma if given too much. In very high doses, they can completely suppress the nervous system and people can die. And these drugs have a very high potential for addiction. So anxiolytics include benzodiazepines or benzos, and this is like Valium, Xanax, Klonopin, lorazepam. They're used for anxiety, so general anxiety disorder, phobia, etc. Sleep issues, helping people get to sleep, and then before surgery to help people relax. Sedative hypnotics are in general considered more dangerous than anxiolytics because high doses are more likely to cause death or serious injury. Prescriptions of these drugs are very highly regulated in most states. According to some of my drug-addicted patients, there have been some new regulations in Hawaii recently making it even more difficult to get these prescriptions. Overdose is more likely to be fatal compared with benzos, and sedative hypnotics include barbiturates. That's kind of a major category, and these are typically used as anticonvulsants for general anesthesia, for very severe migraines that are refractory to other treatments, and in the case of euthanasia where that is legal, or I suppose where it's not legal too, this is sometimes used. So examples of this are like Amitol, which is a sedative, Luminol, which is an anticonvulsant or a medication to help treat seizures, phenobarbital, secobarbital, and secobarbital is the one that I think is most commonly used for euthanasia, at least in pets, and I think in people too, in the case of euthanasia of a human. There's a compound called sodium amytal, which used to be used, I think, like back in the 50s. It was considered like a truth serum, and really it's just like a bit of a sedative. So it reduced inhibition, kind of slowed thinking, and made people less able to be lie and more likely to be disinhibited and tell the truth. And sedative hypnotics include alcohol too. So the official name for alcohol is ethanol, and you might see it abbreviated as ETOH. Other anesthetics include GBH, which in medicine, for medical reasons, is used for narcolepsy treatment sometimes. In small doses, it can be used recreationally as a stimulant and an aphrodisiac, but it's most commonly known as a date rape drug. So in larger doses, it can cause extreme sedation and memory loss. It's not easily detected in urine, so in the case of people suspecting GBH in a date rape case, a urine test will not be effective soon after a reported rape, but it can be detected in hair. So in the case of investigation of a date rape, sometimes hair can be used to figure out if GBH might have been involved. And notably, it can cause a salty taste in drinks. So if you ever find your alcohol to be extremely salty, possibly beware. Dissociative anesthetics cause dissociation, hallucination, euphoria, so some kind of psychedelic experiences. And these include ketamine, which is also known recreationally as Special K, which causes memory impairment, paranoia, agitation at its worst. And it's actually an animal model for schizophrenia because its tendency to cause dissociation, hallucination, and paranoia. Then phencyclidine, which is PCP, or known by its street name angel dust, used to be used medically but is no longer common. It's pretty much exclusively a recreational drug these days. And nitrous oxide, which is also known as laughing gas or whippets, is used commonly in surgery and dentistry, and it's also used in food containers like whipped cream cans to propel the food. It increases norepinephrine transmission, which later on increases endogenous opioid release. So the neurotransmitter action of these anxiolytics and sedative hypnotic drugs, the GABA-A receptor is a common target. GABA, if you remember from previous chapters, is the main inhibitory neurotransmitter in the central nervous system. Makes sense, GABA, that these sedatives and hypnotics, which have this dulling and sedating effect, would act on the inhibitory neurotransmitter. So sedative hypnotics in particular increase the time that the pore is open, allowing chloride, which is a negative ion, to come through, and benzos just increase the frequency of the pore opening. And this influx of the negative ion creates a more negative charge in the cell, which makes an action potential less likely, so it just decreases neuronal activity. Taking any of these substances together, benzos, alcohol, barbiturates, can be very dangerous because they have this additive effect. They all have the same effect of slowing down neuronal functioning, and can be very dangerous when taken together. A lot of these anxiolytics and sedative hypnotic drugs are useful as anticonvulsants, so they're useful for suppressing epileptic activity, because seizure or epilepsy is excessive synchronized neuronal activity in the brain, also conceptualizes electronic storms in the brain, so it's just way too much neuronal activity in the brain. And so some of these medications, these anticonvulsants, reduce the excessive neuronal activity by increasing the activity of GABA in the brain. So the second group is antipsychotics, and these are used to treat psychosis typically. Psychosis is, in general, the loss of contact with reality. So the most common symptoms of psychosis are hallucinations, or seeing things and hearing things that aren't there, and delusions, which is believing things that are very clearly not true. Antipsychotics are used to treat mostly schizophrenia, bipolar disorder, especially bipolar disorder with psychotic features, and they're also used to treat agitation in older people with dementia, agitation in autism, and obsessive compulsive disorder. There are two main groupings of antipsychotic medications. There's the first generation, or typical antipsychotics, which came around in about the 1950s, and this includes Thorazine, Haldol, Prolixin. These are mostly dopamine antagonists. So antagonists, if you remember, means that they block the transmission of this neurotransmitter. So they block the transmission of dopamine just by blocking this one receptor, the D2 receptor. The benefits of typical antipsychotics is that they're less expensive. They've been manufactured for a long time now, so they're used in a lot of lower resource areas, and also like the state mental hospital a lot of times will use these typical antipsychotics for individuals who don't have very good health insurance, or not a lot of money in general. The con of these is that they have higher levels of side effects. So antipsychotics in general can be difficult to stay on because they have a lot of really negative and what can be serious side effects. One of the more pronounced it's not super common anymore, but used to be a big problem, especially a couple of decades ago, is tardive dyskinesia, which is uncontrollable mouth movements. And you can watch a YouTube video of someone experiencing tardive dyskinesia. Another is Parkinsonian symptoms. So if you remember, Parkinson's disease is caused by not enough dopamine in the nigrostriatal part of the dopamine system. And so by suppressing dopamine it kind of creates this like Parkinson syndrome, which is known in psych hospitals as the Haldol shuffle. And you can see what that looks like if you follow this YouTube link. Second generation or atypical antipsychotics include Clozaril, Zyprexa, Seroquel, and Vega-Geodone. And these are dopamine serotonin antagonists. So they block both the D2 receptors that were blocked by the typical antipsychotics, as well as serotonin 2 receptors. Serotonin 2 receptors may act by upregulating D2 receptors later. So the antagonism of serotonin leading to the antagonism of dopamine in these areas. They may target, since there are like 4 dopamine pathways in the brain, there's a possibility that they just target the parts of the brain where dopamine is dysregulated better than the typical antipsychotics. So the benefit, they're generally more effective. Side effects are generally considered less serious, so they're less likely to have these motor side effects. The negative is that they are more expensive, and they are associated with weight gain, and sometimes extremely profound weight gain, which can of course be dangerous. It can cause diabetes and also just a decreased quality of life in individuals who are taking these medications. There's quite a bit of research looking for a 3rd generation or a 4th generation, just more types of antipsychotics that may have fewer side effects and better target other symptoms of schizophrenia. So most of the antipsychotics currently target the positive symptoms of schizophrenia, so the hallucinations and the delusions, and they don't target what we call the negative symptoms of schizophrenia, which is avoiding social contact, a lack of motivation, blunted affect, or decreased ability to feel pleasure. A lot of those negative symptoms are not targeted by antipsychotics at this time, and so a lot of people are trying to develop medications that might target the negative symptoms as well. So there's this possible 3rd generation antipsychotic, which is a dopamine partial agonist, they think. They're not totally sure what the mechanism of action is. Abilify is an antipsychotic medication that might fit into this category. And it's believed that it might antagonize dopamine in the mesolimbic pathway, so prevent dopamine in this mesolimbic pathway, this kind of like frontal, this like prefrontal and basal ganglia area, and then be an agonist in the the mesocortical pathway, which there's some belief that there might actually not be enough dopamine in that particular dopamine pathway in schizophrenia. So, kind of as I mentioned at the beginning of this chapter, really complicated. The mechanisms of action are not very simple for a lot of psychotropic psychoactive medications, and similarly the neurotransmitter dysregulation in a lot of psychological disorders is extremely complicated as well. Okay, so group 3 is antidepressants and mood stabilizers. Antidepressants are typically prescribed for depression, but they're also prescribed for a range of psychological disorders. They're kind of add-ons or even like first lines of treatment for a lot of psychological disorders. So people with anxiety will often get antidepressants, people with obsessive compulsive disorder, PTSD, eating disorders. Actually, there's a lot of indication that antidepressants help with anorexia and bulimia, as well as addiction and chronic pain, or pain that is believed to originate in the central nervous system. So antidepressants work as agonists on many different neurotransmitter systems, serotonin being the most common, but as well norepinephrine, histamine, acetylcholine, possibly even dopamine. A lot of antidepressants have negative side effects, including sedation and sexual dysfunction. One of the first types of antidepressants were monoamine oxidase inhibitors, or MAO inhibitors, and these stopped MAO from breaking down serotonin in the axon terminal, so creating a greater amount of serotonin in the axon terminal, which would create more transmission of serotonin. MAO inhibitors had some potentially dangerous side effects. You couldn't eat certain types of foods on them, and so in general, they are not prescribed very frequently anymore. There's also tricyclic antidepressants, which I won't go into much, but they essentially target monoamines as well, so serotonin, dopamine, etc. Tropinol is an example of this. And then second generation antidepressants are the ones that you see more of. You see more people prescribing those. So the most common or the most well-known one is selective serotonin reuptake inhibitors, or SSRIs. This includes Prozac, Zoloft, Paxil, Celexa, Lexapro. The mechanism of action is it hasn't been proven yet, but very likely that it inhibits the reuptake of serotonin in the synaptic cleft, as its name insinuates, thereby increasing the serotonin activity at postsynaptic receptors. So it stops the serotonin from being taken back into the presynaptic cell, leaving it in the synaptic cleft longer, which increases the likelihood that more serotonin is going to bind to serotonin receptors on the postsynaptic cell. There was a bit of a controversy a while ago about increased risk in suicide for adolescents and young adults. I think it was specifically it might have been Paxil, where there was people, especially young people, who took Paxil or antidepressants were more likely to commit suicide. And this, it's still not totally clear why this would be, but it could be due to the effects of the drug, so increased agitation when taking the drug. And a lot of people believe it might be due to increased motivation in severely depressed individuals. So if a person who's very depressed is suicidal and medication brings them to a point where they're just a little less depressed, they might now have the motivation to actually carry out plans of committing suicide. So a lot of times prescribers will be very careful in giving antidepressants to younger individuals for this reason. Okay, so the other type of second generation antidepressants, or I suppose another common type that you'll see is serotonin norepinephrine reuptake inhibitors, and just as the name suggests, these likely inhibit both the reuptake of serotonin and epinephrine, thereby increasing serotonin and epinephrine activity at postsynaptic receptors. And common ones that you'll see are Cymbalta, Tofacine, and Effexor. And then there's mood stabilizers. So these are typically prescribed for bipolar disorder, which, as most of you probably know, is depression plus mania. Mania being excessive motivation, feelings of euphoria to an extent, and for a long period of time, such that it impairs somebody's life. Some antidepressants can actually induce mania in somebody who has this who has bipolar disorder, and so mood stabilizers are indicated for individuals who have both these very high moods and very low moods. Mood stabilizers in general treat mania better than they treat depression, so they'll bring down the highs, but they don't always bring up the lows as much as one might hope. Types of mood stabilizers include lithium, sodium valproate, Tegretol, Lamictal. Many anticonvulsants are also mood stabilizers, likely because they reduce the neuronal excitability during manic states. So if you remember back when we were talking about anticonvulsants, the proposed mechanism of action is that they reduce GABAergic, they increase GABAergic function and reduce neuronal excitability in general during epileptic states. And there's indication that there's excessive neuronal activity during manic states, and anticonvulsants can kind of bring this down. However, in general, the mechanism of action is largely unknown in many mood stabilizers. They likely decrease norepinephrine, which there's too much norepinephrine in the brain during mania, and likely increase serotonin a bit too to help with the depression. They also might help to regulate circadian rhythms, or like sleep-wake cycles, which are typically highly dysfunctional in people with bipolar disorder. And they might also increase brain growth factors, so increase brain plasticity and the growth of neurons. If you look over on the right, on the bottom, there are different types of mood stabilizers that have different effects. So some mood stabilizers, such as lithium and valproate, bring down the mania more than they bring up the depression, whereas these other ones are might be more likely to bring up the depression and don't have as much of an effect on the mania. And so people who prescribed mood stabilizers will take that into account. We'll decide which mood stabilizer they want to prescribe based on if somebody has more extreme mania and less extreme depression, etc. The fourth group of psychoactive drugs is opioids, or opioid analgesics. An opioid is any chemical that binds to morphine-sensitive brain receptors, or also known as opioid receptors. So it's just essentially any chemical that binds to these opioid receptors is an opioid. Opioid analgesics are opioids with either narcotic or sleep-inducing effects, or pain-relieving or analgesic effects. Opium is a plant that provides raw materials for a lot of the exogenous opioids. So codeine, morphine, and heroin are all synthesized from opium. And then there's endogenous opioids, which are called endorphins. Endorphin is kind of a short form of endogenous morphine. And endorphins are opioid peptides that act like neurotransmitters in the brain. So they have the same effect as morphine, heroin, opium, and codeine. Morphine is extremely potent and very effective, and also extremely addictive. It's actually the most effective analgesic that we know of. We've never been able to synthesize something that's more effective than morphine. Heroin is synthesized from morphine. It is more fat soluble and therefore penetrates the blood-brain barrier more quickly. The faster effect is one reason that heroin is extremely addictive. So it's the most addictive drug that we know of, at least that's in relatively common use. And tolerance to heroin is built very quickly, so it can be a very dangerous drug. Synthetic opioids like hydromorphine, methadone, oxycodone, they're also very addictive when they're used regularly, and this is even when they're used as prescribed. So I think there's kind of a misconception sometimes that anyone who is addicted to pain pills has used them, has abused them in a sense. But some people with chronic pain, they just kind of have to make a hard decision about pain pills, and even when they're prescribed and they're using them as they're prescribed, they can become addicted. Competitive inhibitors are opioid receptor antagonists. So if someone overdoses on an opioid such as morphine, they can take naloxone or naltrexone, and this will block opioid receptors and hopefully prevent somebody from dying from this overdose. So group 5 is called psychotropics. Just a quick note, psychotropic is a term that's often used as just a general term for any psychoactive drug. For the sake of simplicity, we're going to stick to the book's definition of psychotropics, which is stimulants, specifically, that affect mental activity, motor activity, arousal, perception, and mood. The first group of psychotropics is behavioral stimulants, which increase motor activity, alertness, and mood. So this includes amphetamine, which is a dopamine agonist. It increases the transmission of dopamine. And it does this by blocking the reuptake of dopamine and also stimulating presynaptic dopamine release, so stimulating the release of vesicles filled with dopamine into the synaptic cleft. Overuse of amphetamine can lead to heart issues, and extreme overuse can lead to psychosis, so hallucinations and delusions. Methamphetamine is an amphetamine derivative, most commonly known as like meth, speed, ice. Obviously, in Hawaii, there are a lot of big problems with meth, and meth has the same general action as amphetamine. ADHD medications are actually typically amphetamines. So Ritalin, for example, is an amphetamine, And its action is that it blocks dopamine and norepinephrine reuptake transporters, thereby increasing norepinephrine and dopamine transmission in the brain. It's associated with improvements in attention and reduced impulsivity. Cocaine comes from the coca shrub, which I think is primarily in South America. This blocks dopamine reuptake transporters, so again, blocks dopamine reuptake, and derivatives such as Novocaine are still used as topical analgesics. So if you're getting like surgery on your skin, like stitches or something like that, or if you're dental surgery, they'll often numb you with Novocaine. And this is actually a derivative of cocaine. Novocaine's action is that it reduces the permeability of the cell to sodium ions and therefore inhibits nerve impulses. So if you remember, in action potentials, sodium ions are rushing in and it inhibits this process. Psychedelics and hallucinogenic stimulants are the next group. These create changes in cognition and sensory perception. At high doses, many stimulants have hallucinogenic effects. These are often referred to as psychedelics. So acetylcholine psychedelics work on the acetylcholine system, and this includes nicotine, which is an agonist. It increases activity at the nicotinic acetylcholine receptor. There are two general types of nicotinic acetylcholine receptors. There's like the muscle type, or also referred to as N1, and this is mostly in the somatic. It's exclusively in the somatic nervous system. And then there's the neuronal type, N2, and this is in the central nervous system, and that's the one that's targeted by nicotine. Activation of these receptors triggers other neurotransmitter function, especially dopamine in the mesolimbic pathway, which is the mechanism by which nicotine becomes addictive. So you can see to the right, this brain picture, the purple pathway is this mesolimbic pathway, if you remember from when we learned about dopamine, and this is the pathway that's associated with addiction. We'll talk about this in a little bit more detail later. Anandamide psychedelics are, anandamide is a endogenous neurotransmitter, so it occurs naturally in the brain, and it's mediated by cannabinoid receptors. So cannabinoid receptors should probably actually be called anandamide receptors, but we discovered cannabinoid affects these receptors before we discovered that this endogenous neurotransmitter, anandamide, is probably the reason these receptors exist in the brain. So they're called cannabinoid receptors. Anandamide enhances the pleasurable neural response to food. So if you have ever observed someone who is high on cannabis, is more likely to want food, or really wants like junk food. Part of the reason for this might be the activation of these anandamide receptors is associated with pleasurable responses to food. It's also found in chocolate. The activation of these receptors has an anxiolytic effect, and cannabidiol may increase as well. So THC, which is the main psychoactive chemical in cannabis, binds to the cannabinoid receptors, so the same receptors as anandamide, in the central nervous system, and it also binds to receptors in glial cells and in the body. THC impairs motor function, impairs memory function, so it's a well-known that smoking pot can affect your short-term memory, and it also has anxiolytic effects, so anxiety-reducing effects. Glutamate psychedelics are the ones we spoke about before, which were anesthetics. They cause hallucinations, dissociation, and also euphoria. So these are all schizophrenia-like or mania-like symptoms. These include ketamine, PCP, nitrous oxide, and also DXM, which is an active ingredient in a lot of cough syrups. People sometimes abuse it, and it's called robotripping if it's used recreationally. This is the reason that cough syrup the purchase of cough syrup, especially by underage individuals, is regulated in a lot of states. Part of the action of glutamate psychedelics is the antagonism, so the reduced transmission of glutamate NMDA receptors, and several other neurotransmitter systems in addition to glutamate are affected by this. Okay, so please note that the information on the slide is going to deviate a bit from the text. Mostly I've just characterized or categorized some of the psychedelics differently. I'm putting them all into the category of serotonin psychedelics, or everything on this page. It will go into serotonin psychedelics because they mostly act on serotonin. I think it's a better characterization. Please do note that anytime my slides deviate from the text, we're going to use my slides as the, I don't want to say final word, but any conflicting information, use my slides as the answers for homework or exams. In general, I will try to avoid putting anything on homeworks or exams that is represented differently in my slides in the text. Okay, so moving on to serotonin psychedelics. These mostly act as agonists in the serotonin system, so they mostly increase the transmission of serotonin, but many of them also have effects on norepinephrine and dopamine. The first one, mescaline, is found in several different cacti, including the peyote cactus, and has been used for over 5,000 years in Mexico and parts of South America, a lot of times for like spiritual reasons. It binds to the serotonin 2A receptor. LSD, or acid, also an agonist of several different serotonin receptors and directly increases dopamine transmission as well. Conversely, psilocybin, or psychedelic mushrooms, indirectly increases dopamine transmission, though it's also an agonist of several different serotonin receptors. So LSD and psilocybin have similar neurobiological mechanisms, but they're a little bit different, and similarly the perceptual and psychological effects of these two drugs are relatively similar, but also have slight differences. The next one, MDMA, which is also known as ecstasy-E, or in its pure form is known as Molly, often creates euphoria, increased sociability and empathy, and mild hallucination. It's often used as a rave drug, in part because it makes people feel closer to the people around them. And this one also increases the release of serotonin, the release of presynaptic serotonin specifically, as well as norepinephrine and dopamine. Other stimulants include caffeine, which works as an antagonist of the adenosine receptor. Adenosine is a compound that typically creates sedation, slows down the heart rate. So as an antagonist to the adenosine receptor, caffeine kind of inhibits sedation and is associated with a higher heart rate. It indirectly increases dopamine transmission in the striatum as well, which means that it affects the reward system, so people can be both psychologically and physically addicted to caffeine. Other stimulants, and these are not included in the book, but I think they're important. Khat is a stimulant that's grown mostly in the Horn of Africa and the Arabian Peninsula, although it's spreading more, especially to the southern part of Africa. Its effects are increased alertness, mild euphoria, reduced appetite, and in large doses can also cause psychosis. There's a compound of khat called kathione, and this is the active compound that causes these effects. Kathione facilitates dopamine transmission and also inhibits the uptake of epinephrine, norepinephrine, and serotonin. Kathione is actually similar chemically to the antidepressant bupropion, or Wellbutrin, which is a type of antidepressant we didn't talk about because there aren't many that have this chemical action. So Wellbutrin is an NDRI, or a norepinephrine dopamine reuptake inhibitor, meaning it inhibits the reuptake of norepinephrine and dopamine, or increases the transmission of norepinephrine and dopamine. It's Wellbutrin is also used for smoking cessation and ADHD. In its synthetic form can be rather dangerous, actually, since synthetic cation is one form of bath salts, which is a type of drug that's several different chemicals are characterized as bath salts, and they're called this because they look kind of like Epsom salt, or like salts that you would put in a bathtub. The problem with synthetic cation or bath salts is that they're not well regulated, and people end up taking them in doses that they don't expect, or they're cut with something, they're impure. But synthetic cation does have effects that are somewhat similar to cat. Other stimulants, the betel nut, people in Hawaii might be familiar with this because it's rather prevalent in Melanesia, Micronesia, Southeast Asia, and India. It has a stimulating effect, so it's typically, I think, chewed. It's combined with other things to make it taste better, or to make it easier to be chewed, and it has a stimulating effect that's similar to nicotine. The effect of betel nut is that it's a partial agonist of muscarinic acetylcholine receptors. And unfortunately, there's some indication that it's carcinogenic, cancer causing, especially mouth cancer, as it's chewed. So there are different responses that people have to the same drugs. In particular, there are a couple explanations on why people may behave differently on alcohol. One proposed explanation is the disinhibition in general and lack of impulse control. So there's research that indicates that the higher cognition areas, like the cortical areas of the brain, are more affected by alcohol as compared to the subcortical or more basic processing areas of the brain. So the idea is that when someone consumes alcohol, the basic areas of the brain are driving behavior more than the higher cognition areas. In particular, there's evidence that the frontal lobes, which are responsible, as you know, for decision making and reasoning, may be particularly affected even as compared to other lobes such as temporal and parietal. Another explanation is learning. So people have expectations for how they might act under the influence of alcohol. If people think that they're going to get in fights and get really emotional, things like this, when they're using alcohol, they're more likely to act in this way. In fact, there have been studies done where people are told that they're drinking alcohol and they're not, and they act in ways that they expect people under the influence of alcohol may act. Another explanation is behavioral myopia. So if someone is myopic, they're nearsighted. People under the influence of alcohol seem to respond to what's in front of them, so more immediate and salient information, while possibly ignoring longer term implications, more abstract implications of their actions, as well as more nuanced information. So they're not as able to kind of process more complicated information and sort of act within this more basic framework. A quick note, because I am relying heavily on the text for a lot of the material, your book does state that behavioral myopia can lead to risky behaviors due to lapses in judgment, and they included date rape in this. And I have to respectfully disagree with your book on this point. According to information from the National Institute on Alcohol Abuse and Alcoholism, there isn't evidence that alcohol creates a judgment lapse in people who didn't already have a problematic view of sexual consent. And you're welcome to follow this link if you'd like to follow up on that. The idea is that research doesn't appear to indicate that someone has completely equitable and respectful views of sexual consent, drinks alcohol, and then commits date rape. It appears more that people who already have problematic views of sexual consent, so maybe don't fully respect sexual consent, are disinhibited by alcohol and therefore are more likely to commit something like date rape. Okay, so individual differences in addiction and dependence. In general, substance use is the pattern of use of a substance that is excessive and harmful due to the amount of the substance that is consumed. The Diagnostic and Statistical Manual, the DSM, which is kind of the handbook for diagnosing mental disorder, doesn't actually distinguish between substance abuse and dependence any longer. So it's just different levels of substance use disorder that we diagnose anymore. Physical addiction is a physical dependence on a substance. So people that are physically addicted develop a tolerance where they need increased amounts of the drug to get the same effect. They experience withdrawal when they cut back or cease use of the substance. And there's also psychological addiction, which is a psychological need for a substance that isn't that isn't rooted necessarily in the purely physical effects of the drug. And you can look at this graphic up here to the right, showing harm caused by drugs is often harm caused by drugs is calculated based on the harm to the user and the harm to other people. And interestingly, alcohol, which is legal, is considered one of the most harmful drugs, especially in its harm to other people, which is kind of more proportional. More than half of the harm is harm to other people. Whereas heroin, which is highly addictive, is more likely to be harmful to the individual using it. And methamphetamine, extremely harmful to the individual using it, but not so harmful to others in general. Individuals have different responses to drugs, as I touched on earlier. So weight, height obviously can have an effect on how someone responds to a drug. Females may be more sensitive to certain drugs, as estrogen appears to interact with the addiction reward system in the central nervous system. In general, in terms of epidemiological studies, men are still more likely to abuse substances. And this is based on data from SAMHSA, which is kind of the main, one of the main funding and research agencies for mental health and substance abuse in the US. So if you look at this graphic, down at the bottom, men are more likely to abuse alcohol, and if you take, women are more likely to abuse, pain relievers, prescription pain relievers, and amphetamines. If you look at the numbers overall, men are a little bit more likely to abuse drugs based on treatment admissions. So it's possible that there's some chance that women have similar levels of addiction but are not as likely to seek treatment. It's possible. I don't think we necessarily have a final word on that. Older people are more sensitive to drugs in general. The same drug can have the same effect on older people. So for psychotropic medications, it can be important, or psychoactive medications, it can be important to make sure that age is taken into account. This is just a nice graphic showing social harm, likelihood for dependence, and physical harm so harm to the individual of different drugs. So it's interesting to see discrepancies between these three types of harm. So for example, tobacco has relatively high dependence compared to the physical and social harm it causes. Alcohol, again, appears to have relatively high social harm compared to level of dependence and the harm on the individual. Ketamine can cause relatively high harm to the individual compared to social harm and dependence, and heroin is just overall scary and terrible. There are several theories for why people use drugs, and the one that your book mentioned is this wanting and liking theory, which is supported by a fair amount of evidence. It's also called the incentive sensitizing theory, and this theory says that the desire for drug is elicited by cues associated for the drug. So the idea is like wanting, which is craving, is mediated by a different part of the brain as compared to liking, which is pleasure. So wanting is proposed to be mediated by the mesolimbic dopamine pathway, or the reward pathway, which is kind of what we think of also as like the addiction pathway. And then liking, which is the experience of pleasure again, is mediated by the opioid systems. And this theory, the wanting and liking theory, suggests that people start taking the drug because it's pleasurable, it activates the opioid systems, but then it kind of hijacks this mesolimbic dopamine pathway, this reward pathway, and people continue taking it because of cravings rather than the actual pleasure that this drug provides. And this is backed up somewhat anecdotally by reports of people who have been addicted to drugs, especially highly addictive drugs such as heroin, who say that they don't so much enjoy, like the drug doesn't necessarily give them the same pleasure it did. They don't get the high that they used to, but they crave it and they need it, and they might also be using it to avoid the withdrawal symptoms, which can be extremely averse. So there's indication of different types of addiction, differences in the reward learning and learning of the association between the stimulus and reward, and these multiple forms of addiction are just based on Pavlovian classical conditioning. So if you remember, Pavlov gave a dog meat powder or something like that, and then rang a bell, and eventually the dog would salivate to the sound of the bell in anticipation of the meat powder. And it's an unconscious association where a previously neutral stimulus, such as the bell, becomes associated with a pleasurable stimulus, the meat powder. And so the proposal is that something similar is happening in addiction, at least for some people, and that there are variations in this type of classical conditioning that accounts for some individual differences in addiction behavior. So the two types are sign trackers and goal trackers, and this is a pretty broad generalization, but in general, for sign trackers, the cue stimulus is actually irresistible. So the dopamine pathway, this mesolimbic pathway, has been hijacked and is associated with a cue, such as maybe a syringe, and the cue is actually sought more than the actual drug. So the cue is sought in the absence of the pleasurable experience. So more than the effects of the drug is what I'm saying. So actually using the drug is more pleasurable than the effect of the drug. So for example, the person will find just the sight of the drug cue pleasurable, and again, this is supposed to be mediated by this dopaminergic mesolimbic pathway. The other type is goal trackers, where the cue stimulus is not as irresistible as in sign trackers, but rather they seek things that are more relevant to the actual pleasurable stimulus. So they won't find just drug cues as independently pleasurable, but will actually try to get the actual drugs. And this is believed to be not as heavily mediated by the dopaminergic mesolimbic pathway. Due to cue salience, an important part of relapse prevention in drug treatment is avoiding having the client avoid the people, places, or things associated with drug use, and that can be really hard, especially in a place like Hawaii. It can be really hard to get away from your dealer, get away from friends that you might have used with. Even sometimes people have to end relationships where their partner was a drug user along with them. Even like moving to a new apartment or something, moving to a new neighborhood can be a really important part of avoiding relapse, because in part they're avoiding these cues. So the mesolimbic pathway, we've been talking about that a lot. To go into a bit of detail, it's this reward pathway, it's a dopaminergic pathway, and it's involved in the feeling of motivation and reward. So motivation to do something or to attain a certain reward. And it's not just involved in drugs, it's involved in a lot of different pleasurable experiences and motivation in general, but it's the part of the brain that appears to be dysregulated most heavily when somebody is addicted to drugs. So it's composed of these dopamine releasing neurons that project from the ventral tegmental area down here in the midbrain, or the VTA as it's often called. to the nucleus accumbens, which is part of the basal ganglia, and then that goes through to the prefrontal cortex as well, which, if we remember, is responsible for motivation, reasoning, all the higher level processes. The mesolimbic dopamine pathway also receives input from the hippocampus, which is associated with memory and learning. The amygdala, which you remember, is associated with emotion, particularly strength of emotion. And then the medial prefrontal cortex, which is associated with memory formation, among other things. The mesolimbic dopamine pathway also includes glutamate and GABA neurons, so excitatory and inhibitory neurons. So you see there are kind of a lot of brain systems involved, even though it's mostly, or the primary function is dopamine transmission, but lots of different areas of the brain are involved, and a number of different neurotransmitter systems are involved as well. Importantly, susceptibility to drug abuse can have genetic components, and I think this is important to understand for a number of reasons. Some people who haven't had, some of us who have not had addiction problems might find it difficult to understand how somebody can continue using drugs even if it ruins their life. And I think a big part of that is just having literally a different biological makeup as well as different environmental influences. But the genetic component of drug abuse can be as much as 50%. For nicotine, alcohol, and a number of other drugs. As is the case for most psychological disorders, genetic susceptibility to drug abuse is likely a combination of many different genes. Different gene combinations can have the same effect of making people more likely to be addicted to drugs. So it's not a matter of finding like the drug gene, it's lots of different genes and lots of different interactions between genes that give people more or less of a susceptibility to drug addiction. Epigenetics, unfortunately, can also affect the heritability of these genetic components. So if a parent uses a lot of drugs, that can reduce the expression of genes that are related to voluntary control, and they can pass on this reduction of expression of voluntary control genes, creating more problems with inhibition, behavioral inhibition in their offspring. Oh, and notably, the genes involved in increased susceptibility to drug abuse might be related to learning, to dopamine, frontal lobe functioning, impulsivity, kind of all these components of drug use. Okay, so section 4, explaining and treating drug abuse. There's definitely indication that prolonged drug abuse can cause brain damage. In particular, growing brains are sensitive to drug abuse. So kids in general should just not use drugs, and certainly not habitually. The frontal lobe can be particularly affected by drug use, and the frontal lobe is the last part of the brain to stop developing, and development can continue into the 20s, possibly even to the 30s for males. So frontal lobe development is a little bit slower in males, and so can extend longer, even into the 30s. PCP, ketamine, and DXM, which, as we talked about before, create excessive glutamate transmission. Glutamate can trigger apoptosis or cell death, and so use of these drugs can actually kill cells in the brain, and will kill cells in the brain with extended use. MDMA or ecstasy, brain changes have been observed from long-time use. So MDMA is associated with excessive serotonin transmission, and can cause, with chronic use, can cause lesions in the serotonergic pathways, loss of gray matter, the neocortex, the really important part of the brain, can cause cognitive impairments and depression. So the dopamine parts of the brain get impaired, so there's not as much serotonin transmission, causing depression. And then methamphetamine can decrease dopamine transmission because it can damage the dopamine pathways, and as well make the dopamine pathways resistant to endogenous and natural transmission of dopamine. Some people with really long periods of methamphetamine use develop what is essentially the same as schizophrenia, so prolonged and chronic psychotic features, even when they abstain from methamphetamine. If you look on the right, you can see at the bottom right, brain recovery with prolonged abstinence from meth. So there is some indication that after long-term abstinence from meth, the brain can, this is dopamine transmission in the mesolimbic area of the brain, so the brain can recover and have normal dopamine transmission. However, with really intense and extended use, there can be permanent effects that are not reversible. And then up at the top, cortical gray matter volumes. This is showing that individuals who have long-term alcohol use, often we see reduction in gray matter volume. So brain matter is reduced, which is associated with cognitive and emotional issues. Another quick caveat to your text, there is a little box about drug-induced psychosis, in which the authors of your text described a case study where somebody experienced psychosis after using marijuana. A few issues with this. I study schizophrenia specifically in young people, and many of my patients have used marijuana, and there's a big debate as to whether marijuana use can contribute to the onset of schizophrenia, and the data is extremely mixed and highly likely to be misinterpreted. So this particular case study in your book, as with any case study, it should not be overinterpreted. I think it was used as an example, but it should also not be interpreted by itself. In the main study that was cited, only individuals smoking cannabis with high THC had a higher occurrence of psychosis, and it was only a correlation. So as you hopefully know from Psych 100 and your psychology methods courses, correlations don't mean causation. You can never infer causation from correlations. So in the study, there was a correlation between psychotic symptoms in young people, or the incidence of schizophrenia in young people, and cannabis use, this high THC cannabis use. However, we can't prove that the cannabis use caused this. There's an alternative interpretation, which is that people who are at risk for psychosis might be more likely to use cannabis. And there's a number of reasons to believe that this interpretation may be valid. Cannabis has a sedating and anxiolytic effect, also an anxiolytic effect, and so people who are in the prodrome or pre-disease phase of psychosis are more likely to have anxiety and depression and may turn to drugs to deal with this. And there's also some indication that cannabidiol, as I think we mentioned we talked about in a previous lecture, cannabidiol may have antipsychotic properties, so it's possible that people using certain strains of marijuana are attempting to glean antipsychotic properties from cannabis. It's not a good idea to use cannabis to deal with psychological problems, but it could be an explanation as to why there's this correlation between cannabis use and schizophrenia. So just restating that it's best for people with psychosis, certainly best for people with psychosis, and also just best for people with developing brains in general, to stay away from excessive cannabis use. However, it has not been proven by research, and there's been quite a bit of research on this, and it has not been proven that cannabis causes schizophrenia. Okay, so moving on to hormones. There are two main chemical classifications of hormones, and this is steroid hormones, which is just a steroid that acts as a hormone. This includes testosterone and cortisol. These steroid hormones are synthesized from cholesterol, and they're made in the gonads, the thyroid, and the adrenal glands, and they bind to steroid receptors. The other chemical classification is peptide hormones, This includes insulin, growth hormone, endorphins. This is made by DNA, cellular DNA, and it binds to metabatopic receptors that in turn influence second messengers, as you learned in the last chapter. And these second messengers set off chemical cascades that affect cell physiology and gene transcription. There's also functional classifications of hormones. So the chemical classification and functional classification, it's all the same hormones that we're talking about, it's just different ways to classify them. There's the homeostatic hormones, which, as the name suggests, maintain homeostasis in the body. Homeostasis just means like balancing, like keeps the body from not being too cold or too warm, etc. So these hormones are responsible for balance of metabolism, digestive functions. Insulin is one hormone that controls blood glucose levels. So if you know anyone who has diabetes, they might take insulin injections. And this is because the pancreas, which releases insulin, doesn't produce enough insulin in individuals with diabetes, and so their blood sugar can spike and plummet. And so they may inject insulin into their body to help them maintain and regulate blood sugar levels. Hunger and eating are also regulated by hormones. Leptin is secreted by fat tissue, and this hormone inhibits hunger. And then conversely, ghrelin, which is secreted by the gastrointestinal tract, induces hunger. So these two hormones kind of act in opposition to each other. They're called the hunger hormones. Ghrelin is secreted when the stomach is empty, among other things. Low levels of ghrelin in individuals, low levels of ghrelin have been found in people with anorexia. So they might literally just not feel as hungry. And then higher than normal levels have been found in individuals, especially children with obesity. Both leptin and ghrelin signal the hypothalamus directly. Gonadal or sex hormones perform a lot of reproductive functions, create sex-specific phenotypes, so like the gonads are like genitals, and also sex-specific phenotypes like breasts in women and bigger hips and bigger like shoulders and arms in men. They have an effect on the brain and body development as actually before people are even born. So there's a possible influence of prenatal sex hormones on sexual orientation. There's indication that females who are exposed to high levels of testosterone in utero are less likely to be purely heterosexual. There's also some indication that males who are exposed to lower levels of testosterone are more likely to be homosexual as well. One kind of interesting indication of prenatal exposure to testosterone is the ratio between the second and the fourth digit. So the second digit is the pointer finger, and the fourth digit is the index finger. And as the length of your fingers is determined in the womb, this has been pretty strongly correlated with exposure to testosterone in the womb. And so there's been a number of findings that a more feminized or a 2 to 4 digit ratio that's more associated with lower levels of testosterone is equal length of the second and fourth digits. So if you look at the graphic on the right, in women, this is associated with lower, higher fertility, higher risk of breast cancer, lower levels of autism. Autism is associated with higher levels of testosterone, and lower levels of ADHD. ADHD is also associated with, ADHD is more commonly diagnosed in males. In men, this 2 to 4 digit ratio, if the 2 to 4 digit ratio is indicative of lower testosterone in the womb, they also have lower levels of autism, lower fertility, and lower testosterone levels as adults. If there's a more masculinized 2 to 4 digit ratio, men are more aggressive, have a higher tendency toward alcohol, which might be like might be because of impulsivity. They have better athletic ability, which is also associated with higher testosterone in general, a more promiscuous, higher number of sexual partners, and similarly in women, more promiscuous, or more likely to have more sexual partners, interestingly more likely to be anorexic or bulimic, higher levels of homosexuality, which we would, again, has been associated with prenatal levels of testosterone exposure, higher testosterone exposure in females. Puberty is delayed, and women who have this masculinized 2 to 4 to 2 ratio are also more likely to be athletic. There's a ton of studies about this. People are really, really into this 2 to 4 digit ratio and what it correlates with. Just be careful. If you look online about it, just be careful about your sources. Make sure you're getting reliable sources. So sex hormones also, this is a highly contentious subject, but do appear to have some influence on cognition. And of course, as with any population studies, this is on average. It doesn't mean in all cases women have certain advantages. It doesn't mean all women are better at these things and all males are worse, or the other way around. Any study of gender differences is always confounded by environmental effects, and the effect sizes for these cognitive differences in general is rather small. So males in general have appear to have advantages in some spatial abilities, specifically the mental rotation of a 3D object. And then females, on average, appear to have advantages in some verbal abilities. Okay, so the next functional group of hormones is the glucocorticoids, and this is steroid hormones. They're secreted during stress, and cortisol is kind of the most commonly known one of these. Notably, stress can be good or bad. So you might have learned about this in like Psych 100. Eustress is like good stress, a stress that helps you perform better, maybe is like activating, and then distress is bad stress, stress that might kind of inhibit you from being productive. Things like this might be really, really uncomfortable. There are two main types of stress responses in the body. There's the fast response, which is the fight or flight response, and this is mediated primarily by epinephrine, which is also known as adrenaline. And then there's the slow response, which is mediated mostly by cortisol. Extended or excessive stress response can be damaging to the brain and the body as well. So stress responses use a lot of energy, proteins in the body that could have been used for other things. Stress inhibits growth hormones, so there are studies where kids who are in very stressful environments just don't thrive as much. They don't grow physically or cognitively as much as their less stressed cohorts. Stress inhibits digestion, and it inhibits immune functioning. So if you ever felt like you are more likely to get sick the more stressed you are, this is probably true. And then stress response, there's a high indication that it damages the hippocampus, which, if you remember, is one of the main areas implicated in memory functioning. So it can impede memory functioning. There's studies showing that people with PTSD have increased cortical response in response to daily stressors. So they're kind of, people with PTSD in general are just, their body is more ready to respond to stressful situations, possibly because of their past traumas. And so they have increased activation of these stress areas, or these pathways in the body and the brain that are that mediate stress. Okay, and finally we have the anabolic androgenic steroids. So also just known as anabolic steroids. These are synthetic hormones that are chemically similar to testosterone. They have anabolic, which is like muscle building effects. So athletes will use them. They're typically illegal, but athletes will sometimes use them to enhance muscle building and athletic abilities. And they also have androgenic or masculinizing effects. So they will increase like masculine features. They're used medically for testosterone replacement in men. So some men have like low testosterone, so they can be used to sort of replace this testosterone, and also for the treatment of endometriosis in females. There's this form, there's a particular anabolic steroid that is being studied right now as possible male birth control. Females often take hormones to prevent pregnancy in themselves, and there's indication that there may be hormone regulation for men too that would, among other things, suppress sperm production. And this would be reversible, so that if they, just like for women, they can stop taking birth control and get pregnant, for men they would be able to stop taking this steroid, and sperm production, it appears, would return to normal. Anabolic steroids are also used for male to female gender transitions, and here's a video of showing like a 1-year transition of a woman who was on anabolic steroids among a number of other things, who transitioned to male gender, or at least went through the physical transition to male gender at that point. And you can see up top here on the right is someone who went through that transition as well, who was born a female and went through to a male gender transition.